Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget that you can download the PDF of this ECG down in the description below so that you can follow along and make your own notes. And so, otherwise, let's get started. So, first thing we're going to do is we're going to look at the forest, and the trees of the forest are my QRS complexes. And so, if I start maybe here in V5, you see I've got a narrow complex rhythm that seems to be pretty regular, right? And it's occurring on an on dime throughout the entirety of the strip. You can see that if I want to calculate my rate, I like to find a QRS that lands on a solid line, so maybe this one right here. We can count 300, 150, 100, 75, so just closer to 75, but in between 75 and 100, so we'll call this 80 beats per minute. Okay, so I've got a narrow complex rhythm at 80 beats per minute. It makes me think that conduction is being driven through the AV node down to the ventricles. So let's see if that is being caused by some sinus atrial depolarization. So we're going to look at the P wave activity here. So I notice that there are P waves. If you look closely, right here in lead 2, there's P waves, P waves. Remember, P waves are a little bit sharper. T waves are a little bit more broad. If you need help identifying them, you can look in V1. The P waves that we just identified, if you look closely in lead 1, they are upright in lead 1. And in AVF, you can tell that there was a little bit of artifact there, but you can see right here, upright in AVF. So that is a sinus P wave, right? It tells us it's going down and to the left. So now I need to figure out what is my AV node doing, right? And so I can measure my PR interval, and I can observe how the PR interval evolves throughout this rhythm, if it does. And so I look here, maybe I'll go to lead 2, and I'll come over here. So I see my P wave starts here, my QRS starts there, and so that's about 9 millimeters, or 9 small boxes of a PR interval. And so that PR interval is 360 milliseconds. And we know that the normal PR interval should be between 120 and 200 milliseconds. So we would say this is a long PR interval. And so we've got some type of AV block, but now it's our job to do a thorough investigation on what type of AV block, right? A first degree AV block would be that the PR interval is prolonged, but every P wave conducts to a QRS. And then second degree and third degree are progressing from there. And so I look closely, and maybe I come down here to lead V1, and I see I've got P, QRS, P, QRS, P, QRS, and I look closely for any extra P waves that could be hidden within this QRS complex or that ST segment or that T wave, and I don't see any extra P waves, and so because of that, this would be a first degree AV block. Okay. Then the AV node passes that signal down to the QRS complex, and so let's evaluate that QRS complex. It's narrow, right? My QRS duration, my QRS is less than 120 milliseconds. My QRS axis is upright in lead 1, is upright in AVF. So that tells me that the axis of depolarization is down to the left, which is normal, right, for the normal positioned heart. We've got good R wave progression, right? If you look in V1, we have this little septal R wave, right? You gotta look really closely, but it's there, that little bump, that's our little septal R wave that grows and transitions here in V3 to becoming isoelectric QRS to a dominant in V4, so it's very appropriate R wave progression. And we can quickly just eyeball our QT interval. I like to take kind of R to R intervals, find the midway point, and see if my T wave terminates by that point, which it does, so it's normal. And then the last thing I do is I look for history of prior infarcting events via pathological Q waves, and then other ST or T wave changes that could make me think of like ST elevation or depression causing or being caused by ischemia or infarction. And so as I scan through my atomical leads, right? I've got my high lateral leads, I've got my lateral leads, I've got septal, I've got anterior, and I've got inferior, and I don't see any ST or T wave changes that are really concerning. And so let's put this all together, and what do we have? Well, we have a sinus rhythm at 80 beats per minute with a first degree AV block. So remember, when you do see AV block, remember that you need to scan through and make sure before you call it a first degree that you scan through, right? Good, you know, parts of the ECG that you want to worry about are there any new pauses? Is everything on time? And if so, is it a 1-to-1 ratio? And if not, figure out, is the AV node being blocked intermittently? So I hope this video helps. If you enjoy this content, feel free to like this video, subscribe to the channel, and we'll see you on the next ECG video. Take care. Have a good day.